Thank you. Well, it's certainly an interesting time of it as these diseases that we once felt were so remote and exotic are now knocking on our doorstep. So what our aim is today, we need to just learn a little bit of basic information about the virus itself, because hopefully the more we understand about this, the less panic and misinformation that will occur. We need to know about the current disease outbreak and how it may or may not impact us. We need to know the basics of disease transmission. Again, not only to arm ourselves with the necessary knowledge, but to help with some of the really almost hysterical responses that are going on. Lastly, we need to know about what's going on here in the BOP. And we are fortunate to have Dr. Neil DeWitt, Medical Officer of Health, with us here today, who will hopefully have time for a few words at the end. At the beginning? Oh, okay. At the beginning. Okay. In that case, I'd like to turn it over to Neil now, and then we'll proceed from there.
Yeah, thanks, Dan. Thanks for fitting me in at the beginning. I've just got to go to another meeting halfway through. My name's Neil DeWitt. I'm one of the medical officers of health for the Bay of Plenty and Lakes area. So I'm involved with the planning team, getting ready for Ebola. And I think the main thing I wanted to say today was to just keep it in perspective. Obviously, Ebola is something serious. We need to be ready and plan for it. But the risk of a case or a suspected case in the Bay of Plenty and Lakes area is very low. Just to give you some numbers as to give some sense of that, what that actual risk is. Since the public health emergency was declared back in August, we've had a total of 74 people return to New Zealand from an affected country. The vast majority of those, well, more than half, were from Nigeria, and Nigeria is no longer one of the affected countries. And since Nigeria has been taken off the list, we've had one person come back from an affected country. So that gives you some sense of the likelihood of a case occurring in the Bay of Plenty and Lakes area. So the risk is very low, but we need to be prepared. And the important thing to be prepared for us as a health service, as a health sector, is that we can identify a case early, the chance, or a likely case early, a suspected case early. But we really helped with that because there's so much awareness about Ebola at the moment, and obviously anyone returning from an affected area is going to be very aware. It's likely they're going to present early. It's very likely that they're going to volunteer that travel history very, very early on. But across the health sector, we need to be able to detect a possible case early. Then it's because obviously we don't have all the other interventions that we have with other infectious diseases such as vaccines and antimicrobials and antivirals. It's really about doing the real basics of infection control really well. So what we need to be able to do is safely identify a case early, isolate them, assess them, and for us in the Bay of Plenty and Lakes area, most likely transfer them to Middlemore. So the basic patient pathway, whether someone presents in the community, at a GP practice, or phoning Healthline or phoning the GP practice from home, or whether they present at ED, or in our case, because we cover Rotorua Airport as well, at the customs there, where they're asked about their travel history. The immediate actions are obviously to, the basic pathway is isolate right away, and then take whatever measures you need to ensure infection control. They'll be transferred to a place where they can be assessed, most likely be assessed on a case-by-case basis, but Tauranga Hospital is going to be well set up to where the assessment can be done by an infectious disease physician, and then depending on that assessment, they'll be transferred to Middlemore for further management, or further diagnostic testing and further management. So that's the basic pathway, and obviously alongside that, when there's a suspected case, there's the public health response as well, which is all about identifying contacts and taking measures to make sure that there's no risk of any onward transmission. So obviously, we're in a very different situation compared to West Africa in terms of the way we set up. As in a developed country, we've got the ability to do all these things and safely assess and manage a case. And so I think we need to really focus on the scenario that we're really planning for, is to pick up that one suspect case and manage them really well and do the contact tracing around that. So I'm going to end there.
So let's talk a little bit about the viral hemorrhagic fevers. Ebola is only one of many different of the viral hemorrhagic fevers. So the VHFs are viruses from 5 distinct families: the arenoviridae, the bunyaviridae, filoviridae, actually Ebola's filoviridae, that's in our flaviviridae, and the paramyxoviridae. So my main experience is with the arenaviruses and the bunyaviruses. These viruses have a lot of common feature all across the hemorrhagic fever group, and what we learn about Ebola can really be applied to any of these viral hemorrhagic fevers. So there are RNA viruses, they're all envelope viruses, and you being astute healthcare professionals, you immediately go, aha, an enveloped virus is a fragile virus. These aren't ones that are going to float around in the atmosphere for 3 months at a time. Anything that destroys lipids will destroy the envelope on that virus and render it non-infectious. So that's UV light, that's heat, that's desiccation. So these are not hardy viruses that are going to persist in the environment for prolonged periods of time. In general, all of these hemorrhagic fever viruses, their persistence in nature depends on a host that is an asymptomatic carrier. Those hosts are called the natural reservoir. That's where these viruses will just hang out quite happily. Humans are accidental second hosts. When we look at all these viruses, including Ebola, they're geographically limited by where the host lives. So for example, you're not going to see Bolivian hemorrhagic fever in New York City because the host doesn't live there. The only exception to this, and something that is standing New Zealand in very good stead, is when the hosts get moved around from place to place, usually by transportation as a zoo animal, transportation as a pet, or illegal importation of food items. So how do humans get it? The first instance, there's always some bridge where the human comes in contact with the infected host. Then some of these viruses, Ebola and certainly some of the other viruses, there can be human-to-human transmission. But it always starts where the host comes in contact with the human as the initial step. Cases of these hemorrhagic fever viruses have gone on for thousands of years. Okay, they are sporadic, and they are irregular. With all of these hemorrhagic fever viruses, with a few noteworthy exceptions, there are no treatments for any of these. Now, all of the viral hemorrhagic fevers also have disease characteristics in common. That's why they get lumped as viral hemorrhagic fevers. This is a systemic illness. Even though hemorrhage is part of the name and part of the feared complications, these are systemic illnesses. The virus gets into the bloodstream, goes everywhere in the body. Okay. All of these are characterized by an asymptomatic incubation period that can be quite long. The bunyaviridae, it can be up to 28 days, Ebola up to 21 days. So there can be a very long incubation period where the virus is slowly growing and replicating in the body, and then it reaches a tipping point where you become symptomatic. They're all characterized by a capillary endothelial leak and a third spacing of your tissues, fluids. You basically get fluid in your lungs, you get fluid in your tissues, you third space everything like crazy. renal complications, hypotension, and then thrombocytopenia is a key feature of all of these viral hemorrhagic fevers. The bleeding, like I said, is something that's quite difficult to look at, but most people don't die of bleeding. Most people die of end-organ damage. So the Ebola virus. Well, all of these viral hemorrhagic fevers are named after a geographic location where they are first described. So Ebola virus is named after the Ebola River. It's a filovirus. It's one of the few that we've seen that have these long strands. It's a single-stranded RNA virus of about 19,000 nucleotides. Now, there are 5 virus subspecies in this: Zaire Ebola virus, Bundibugyo, Sudan, Typhorus, and Reston. Reston is named after Reston, Virginia, where it was accidentally discovered in a biosafety level 4 lab. And this is Zaire virus in a electron micrograph. These long strands here are the virus inside a cell. So BDV, EBOV, and SUDV have all been associated with human outbreaks in Africa. Reston is found in the Philippines and in the People's Republic of China. Now, Reston can infect both humans and primates. It's the only one of these viruses that causes an asymptomatic infection. Okay. And we basically don't see type fever virus. So when did these human cases of Ebola first start? 1976 was the first recognized outbreak where they were able to find this specific virus. This was found in the Republic of Congo, and that area in the Republic of Congo has remained a spot where there's been intermittent outbreaks since. The origin of the virus is really unknown. The host is most likely felt to be a type of bat, which is a fruit bat. Okay. Humans and non-human primates are accidental second hosts, and humans and non-human primates get sick with the disease. The fruit bat carries it quite merrily as it goes along through its life. I know there's been a lot of press about other mammals getting infected. There's no evidence that dogs, cats, or domestic animals can get infected. If they do, it does not appear to be a significant cause. Specifically, in these large outbreaks going on, we've not seen any die-offs or cats, dogs, or domestic animals. We can infect mice in certain lab situations, but other than that, humans and non-human primates seem to be the primary second hosts. Now, before the big outbreak going on now, most of the smaller outbreaks were really associated with contacts with either bushmeat, which were carrying the virus, or with contact with the fruit bats. We know that there's secondary transmission that goes on with Ebola, and we also know that the people at highest risk are those with direct contact. That includes family members and healthcare workers, and people participating in ceremonies that require touching of the dead body. Right now, with the current outbreak, it's all secondary transmission. It's all human-to-human transmission. There's no more bats going on with what the spread of the virus is going on now. So how do you get it? The key thing is direct transmission. Okay. Through broken skin. If you get an infected type of secreta or body fluid onto your eyes, you can get it directly through the ocular membranes. You can get it through mucosal membranes, and you can get it from any of the secreta of an infected animal. Humans can have it on skin, blood, saliva, semen, vaginal secretions, feces, vomitus, so basically just about anything in the human, in an infected human, is considered potentially contagious. There are, of course, unfortunately, infections that occurred via needle sticks. Okay. There are a few cases where it's been contracted via fomites, mainly heavily soiled clothing and bedding. You can have a respiratory droplet contact when an infected person coughs, sneezes, vomits, or otherwise sprays body fluid out. These small droplets can be breathed into or come in contact with the mucous membranes. It is not an airborne virus. That is, if a person coughs in a room and you're 10 feet away without a mask, you're not going to get Ebola. That said, as we talk about our PPE, we have gone to N95 respirators for up-close personal contact for a matter of safety reasons. Okay. They've also done some experiments where they've had infected monkeys in cages, and they would place an uninfected monkey in separated. The cages were open, but they're separated by plexiglass walls, so there was circulation around the room, but no way for the monkeys to have any direct contact, including the things that monkeys like to do, like throw feces. And the uninfected monkeys did not acquire Ebola through an aerosol route, so it's not an airborne virus. It is not going to mutate to become an airborne virus, at least not in our lifetime. We do not have a receptor on our respiratory epithelium that is appropriate for this to be an airborne virus. Okay. Makes a great movie, but it's not actual. Now, infected males can continue to shed virus in their semen for up to 7 weeks and possibly longer. So the next question that we need to talk about is how transmissible is it? We know there's secondary transmission. We know there's person-to-person transmission. How easily is it transmitted? Well, we know that during the incubation period, virus levels are quite low. And we can sometimes do biopsies and certain things and find low levels of virus in tissues, but they're not going to be in the saliva, they're not going to be on the skin, they're not going to be in the feces, so they're not readily transmissible during the incubation period. And that's why the current practice is if you're asymptomatic and afebrile, then your risk of transmission is essentially zero. Okay. Now, during the acute phase, your virus levels are rising rapidly. Okay. We also know that about 66% of people in the acute phase of the illness will have vomiting and diarrhea, and there's a lot of virus in the vomit and diarrhea. So we know to be quite careful during that acute phase time period. About 18% of patients will have bleeding. We know there's a lot of virus in the blood. Again, things that are heralded that we have to be very cautious and very careful at this time period. Now, in the 1995 Kikwood outbreak, they looked at the secondary transmission rate, and they found that 16% of household contacts to a patient with Ebola virus acquired the disease themselves. Okay, so 16% of household contacts. So yes, there is secondary transmission. It is not 100%, it's not 80%, so 16%. And all of those 16% had direct contact with the index patient. Okay. So again, getting us back to the direct contact. We also know that the advantage of youth and adolescents is that they're able to survive Ebola virus. As you start approaching my age, your risk of disease mortality starts getting significantly higher. There's also new data from the current outbreak that there's a genetic predisposition to survival as well that's still under investigation. There seems to be some correlation with the amount of inoculum that you come in contact with and your subsequent severity of disease, such that some of the healthcare workers who had a very low inoculum actually had fairly mild disease and did quite well, whereas people who have a very high inoculum tend to have worse disease and a more significant fatality rate. Okay, so we've got an Ebola patient here. We've gotten them all bundled up to Middlemore. Now the next question is, what about the room? What about that whole environment? How long does the virus stay viable on the environment? You know, do you need to be worried about getting on an airplane if somebody maybe had been on the seat in front of you? There's been one controlled lab experiment where in a very perfect environment, in a dark room with no UV light and a controlled temperature in a moist environment, in a petri dish, the virus stayed viable for, up to 6 days, although the viability decreased daily. Okay. Now, again, that was a very, very controlled setting. We know that it's very rapidly, in a matter of hours, destroyed by UV light. Okay, so a very practical thing is to hang things out in the sunlight. Okay. We do know it can persist for that 6 to 10 day period in moist organic debris. So heavily contaminated with blood, feces, or vomit, there can be viable virus inside that for a longer period of time. Now, in the field studies, they've gone around some of these hospital rooms and they've swabbed looking by PCR, which will just tell you if there's viral gene segments, not whether it's viable or not. But they've just looked for virus gene segments on some of these commonly handled, hard, non-porous surface like door handles, and they were not able to detect it. The only place they were able to find virus was in bloody or contaminated type fomites. Right now, CDC recommendations are that a properly cleaned room, if it stood down for 24 hours, there's essentially zero chance that there's still viable virus left in that room. In the recent US experiences, they were able to find virus in virtually every part of the infected patient that died, including everything we've listed before. They were able to find virus in soiled linens and bedding. They did not find virus on door handles. They did not find virus on light switches. They did not find virus on other hard, non-porous surfaces. Okay, so now we unfortunately have some high-risk exposure and they're incubating away and they're asymptomatic. The incubation period is quite variable, as you see, and this probably relates to the size of the inoculum. Initial signs and symptoms are sudden onset of fever. Okay, that's almost universal. You can have some intense weakness, muscle pain, headache, sore throat, but again, these are all very nonspecific. That could be influenza. All right, so it's difficult to tell at these early stages. Okay, later signs, vomiting and diarrhea. Okay, low white count, low platelets, petechial or hemorrhagic rash, impaired kidney and liver function, and then they may or may not have internal and external bleeding associated with this. Treatment is supportive care. Here we would stabilize the patient and get them up to Middlemore. Okay, we would not be treating Ebola patients here. But the treatment is good ICU care, correct fluid and electrolytes, support their heart, support their kidneys, support their fluid balance. Okay. It's important that you maintain isolation rooms with limited access to visitors. Right. This can be quite difficult for families, especially when they're quite concerned about their loved one. Dedicated personnel, dedicated equipment, and trained personnel are also the hallmarks of being able to successfully care for a patient and to safely care for a patient. Okay. There are no vaccines that are currently approved for use. There's 5 vaccines in trial. It will be difficult to say what is going to come out of the trials because they're very poorly controlled. There are no specific antiviral therapies that are approved for use. And a lot of this is because of the difficulty in testing these prior to this outbreak. There's very little where you could do human testing with a placebo-controlled. Most of this relies on animal testing, which is a biosafety level 4 procedure. Of the agents that have been evaluated up to now, they have been released for compassionate use. Unfortunately, none of them were really ramped up for use on this scale, so they're not widely available. One of the things going on right now is passive antibody transfer, which has some data in some animal models. We're also trying this now in some of our other hemorrhagic fever virus infections. For passive antibody transfer to work, you have to get it early. By the time you have end organ damage, there's nothing that's going to work. And you've probably all heard about ZMAP, which is, the way they did it is really kind of cool, which was to transfect it into a tobacco plant and get the tobacco plant to manufacture the drug. There's one I'm most excited about is Tecmira, which is a small interfering RNA. And this has now been moved. It started as a Marburg, and now it's been moved to an Ebola treatment. So, okay. It's susceptible to just about any disinfectant. In Africa, in a lot of fields, they use a 10% freshly made bleach solution. Here, we can use our standard hospital disinfectants. Anything that says it's virucidal and it works against norovirus or adenovirus will be effective against this. There does not have to be one standardized disinfectant. So just look at what disinfectants you have. If it works against, if it's virucidal, it'll work against Ebola. Okay. You do need to have safe procedures in place to wash everything down and decontaminate that. You want to avoid any reusable things like reusable linens. Plan on throwing anything that's porous and contaminated away. All right. If possible, we'd like to autoclave or burn any of these, and there are protocols in place. All right. The New Zealand Ministry of Health has a whole multi-page guidelines on how to successfully decontaminate a room. And lastly, there's all kinds of protocols available on Bay Navigator. Now, lastly, I'd just like to go through a little bit about the current outbreak, okay, because it's really been a lesson to us all on how, with our current ways that we can move around the world fairly rapidly, move from city to city fairly rapidly, the porous borders, and a lot of our overcrowded and not particularly hygienic areas where a lot of people unfortunately have to live, this thing is taken off and become a disease that we've not seen before, a very unprecedented outbreak. So it likely started in January of this year, just 11 months ago. Okay. And at that time it started in Guinea. There were 36 cases that were reported. This is a monitored disease. Subsequently, there were cases in March, so 2 months later in Liberia. Nobody had been paying much attention to it. Oh, a small Ebola outbreak. Okay. In Liberia, this virus was sequenced by the Institut Pasteur, and it was found to be a Zaire Ebola virus. So nothing much was done about then. There were not travel restrictions put in place. There was not much in the way of education. There was not much really in the way of trying to contain this at that time. The second wave then began in May of 2014. Okay, now in Liberia we've got 29 cases. Then on 26 May, Sierra Leone had cases. And to this day, cases are still escalating. And if we look at that on the contagion world map, here we are starting with a few cases that now are regionally spreading. This is in May. This is when it really came to the attention of the Western world that, hey, this is more than our usual self-contained small outbreak. Okay. By June, cases had almost doubled. Okay. by the end of June, that was now the largest outbreak in history. Okay. Then we have a Liberian man that brings it to Nigeria, and we get a second outbreak starting to go on in the Congo. And now cases are basically on a tidal wave. And this is where we are currently. So cases in the U.S., so as you know, there was one patient that came in, traveled from a high-risk country, he died. 2 healthcare workers that took care of this person contracted the disease but did not die, and 2 healthcare workers who were tending to patients in high-risk countries came back and became symptomatic after their return. Okay. Spain has likewise had a case. We now have cases in Mali. Nigeria has been declared Ebola-free now. They have not had a new case for 21 days, and all the contact tracing has been negative. But currently there's over 13,700 cases and almost 5,000 deaths. These numbers are crude numbers at best, as many people will not take their family members to hospital. As far as healthcare workers, the current estimates are 1 in every 10 healthcare workers may become infected. So now we're going to talk about how as healthcare workers do we protect ourselves. This is from the WHO website, and it illustrates the current practices on PPE. Practices on PPE have evolved as this outbreak has evolved. Both the WHO and the CDC, their guidelines are now no exposed skin in 95 respirators. And we'll go through that in just a minute. So this is me working with a previous virus that was a viral hemorrhagic fever that was an airborne virus, and we're handling biosafety level for mice out in the field. Okay. Now the thing with PPE is it does not have to be exactly what we show you today. Any PPE that fits the guideline is fine, okay? So don't worry that you don't have exactly what we show you today. So again, the key points are no exposed skin. You need a waterproof or water barrier gown that extends at least down to the mid-calf, all right, with a full surgical hood that covers the head, the neck, and the shoulders. Alternatively, you can have a Tyvek coverall with a surgical hood that covers the head, neck, and shoulders, or you can have a hooded Tyvek suit. We're going to show you the hooded Tyvek suit today because that's what we have here, and that's been increasingly recommendations around the world. An N95 respirator or PAPR. Again, this is not an airborne virus. However, because the virus is capable of high velocity, tiny droplets, we've gone now to an N95. Also because all the N95s are more firm masks and they keep the mask away from your mouth so that there's no chance of virus going through that barrier and contacting your lips or your tongue. Okay. Boots are waterproof booties that extend up to the knee. Okay. Face shield or goggles, double gloves, and a plastic or waterproof apron. The other key points with PPE is that this is a buddy system. Nobody does it alone. Okay. You always have to remember to assemble everything before you go into the room. You know, this isn't one where you go, I left my stethoscope in the other room. So make sure you got everything with you before you go in the room. We are asking only experienced personnel to do this. We don't want our students or our trainees to be doing this. Okay. You need to limit your time in that gear till about 45 minutes, otherwise it becomes quite onerous. All right. You need to limit the whole access to this area. We don't want our infection control room where we have these patients to be in the middle of a busy ward. And lastly, for employee health and occupational health, we need to keep records of everybody that was potentially involved. All right. So now, my lovely assistant here, Kate, we're going to demonstrate how to properly put on and take off PPE using the buddy system. I will be Kate's trained observer. Kate will put and take off her clothes. Come on, Kate, we're recording this.
This can come back.
So as we do this, we have a checkoff list similar to a flight warm-up for an airplane. Okay, we're not going to skip any steps. We're going to take our time. We're going to do it step by step. So our first step is to make sure we have all of our equipment. So the next step, okay, first thing we always do, hand hygiene. All right. So next you put on your first gloves. And this is not a sterile procedure, so we're not using surgical technique. We're just putting stuff on here. Okay. Next step is to put on your coveralls. So you'll step into your coveralls. Now put your arms in. You can zip part way.
Sit them down.
Yeah. That little protective flap, very easy to catch. Okay. I will now inspect your suit to see if there are any holes or tears. All right, you may now put your boots on. The boots go underneath the Tyvek. She already has some covers on her feet. Now you should place on your N95 respirator. Now pull your hood up and zip to your chin. Okay. Now we'll place on the face shield. The face shield may be carefully tightened by the straps on the side. Now ensure your inner gloves are tucked inside your tie back. Okay. Place your outer gloves on. Lastly, hand hygiene one more time. You may now go into the room. When you are in the room, please remember not to touch your face. This can be quite difficult not to touch your face, especially if you cough, sneeze, have an itch above your eye. Okay, so remember not to touch your face. Your hands should remain within your vision at all times. Do not drop your hands below your waist. Do not reach over the patient. If you need something on the other side, walk around the room. Okay. Right. I will now don my protective gear so that I can assist you in taking your gear off. As the trained observer, my job will be when she comes out of the room is to assist her in the decontamination process. I will be wearing a face shield, double gloves, an apron, either boots or shoe protectors, and a face shield. The reason is I could potentially become in contact with contaminated material on Kate. So this is all taking part in a separate area now of the exit of the room. Okay. Okay, Kate. So you spray down all visible surfaces, including hands, feet. And as you do this, you inspect for any soilage, tears, contaminated areas. All right, go ahead and turn around again. Okay, and hands. And over. And rub. Okay. Generally, you need to wait a couple of minutes. It will tell you on your guide to whatever disinfectant, 2 minutes by the clock. All right, Kate, I'm going to help you remove your apron now. Pull your apron away from you. Okay. And place in the discard bin. down, turn around, spray down, turn around, make sure everything's sprayed, and hand hygiene. You may now remove your boots. So we get rid of the dirtiest things first. So that's the apron and the boots. The boots go in a bin for disinfection. Okay, Kate, I'd like you now to remove your outer gloves, rolling them inside out. Now we will remove your face shield. I'd like you to bend slightly forward. Take your face shield by the back, pull it up and over and away from you, and discard your face shield. Now unzip completely. I will help you remove your hood. Now remove from the inside out. Okay. Remove your respirator. Lean slightly forward. Okay. And pull away from your body. And lastly, squirt. Remove your inner gloves. You may now exit the room and take your shower. All right. Now lastly, all of these recommendations are subject to change. I cannot imagine them getting stricter than what they are now. But Bay Navigator is where all of these updates are posted, so I'd recommend that you do check Bay Navigator for information. Lastly, there are one of us on call. There's an Ebola call team, and if you do think that you have a patient to discuss with us, Kate or Michael Adodal from the lab or myself are always on call.